Hello, welcome everyone. It gives me a great pleasure to invite all of you for today's webinar on clinical evidence supporting the use of pre-implantation genetic screening. I am Dr. Sam Balu. I am the Scientific Affairs Manager for PGS, PGD and Claria at MedGenome. I will be moderating today's talk. So to give us all a brief summary, today's talk will be giving us a glimpse into the history of PGS vis-a-vis the technologies, and very importantly, share relevant clinical data that actually shows how PGS is beneficial in IVF practice and how it can benefit couples. The talk will also be focusing a little bit on the VeriSeq PGS platform, which is a validated, peer-reviewed, end-to-end comprehensive solution for PGS. By the way, in case anyone is wondering, PGS is also known now as PGTA, or Preimplantation Genetic Testing for Aneuploidies. It gives me a lot of pleasure to introduce Dr. Kathryn Gebhardt from Illumina, who is going to be the speaker for today. She is a senior clinical IVF specialist for Asia Pacific Japan region from Illumina, and has extensively worked and continues to work day in and day out with clinicians across the region in Australia, Asia Pacific, as well as Japan. She played a critical role in validating and implementing the PGS technologies, earlier aCGH and now next generation sequencing, and integrating it into routine clinical practice. And she also closely works with clinicians and patients to highlight and integrate PGS testing in a clinical setting. And of course, she's an expert in the technology. So without further ado, I will hand over the session to Dr. Kathryn.
Thank you so much, Sam. If I could just get you to confirm that you can hear me.
Yes, Kathryn, we can hear you. Please go ahead.
Excellent. And I will just share my screen and I will get you to confirm that you can see my PowerPoint presentation.
Yes, we're able to.
Fantastic. Thank you so much. And thank you everybody for joining today. Thank you, Sam, for that very kind introduction. And I'm really excited today to share with you some information and especially some clinical data about pre-implantation genetic screening, or PGTA. I will refer to it as PGS in my presentation, just because that's what I'm used to. But I really want to take you on a journey to talk about the early data when we talk about new PGS studies, especially with comprehensive chromosome screening, some of the patient groups that benefit significantly from PGS. And then, as Sam mentioned, I do want to talk to you about VeriSeq PGS, which is the Illumina solution, and the extensive validation that took place and what makes it one of the best performing products on the market and the product with the most proven clinical utility. So I just really would like to start just to get us all in the right frame of mind about why we would do PGS. And I know that there's a lot of controversy still about PGS, and even at the most recent ESHRA meeting in Barcelona, there was a lot of controversy about PGS. And I think it's really important that we understand that there's many different ways to perform PGS, and each different way has its own benefits and perhaps negatives, and its own nuances in how that particular approach can actually impact on the outcomes that we see. And so it's really important that when we look at data from PGS studies, that we also factor in how those studies were designed and the types of patients and the way that the technology was used, and especially the type of technology. So I'm not only going to focus on the good data, I would really like to talk about some of the negative data as well. But I really just wanted to first put us in a bit of a positive mind space about PGS and talk about some of the published benefits of PGS, because there are a lot. So we know that it allows us to detect embryos with aneuploidy or embryos without aneuploidy. And why this is beneficial and what the published studies tell us is because this can help mitigate the effect of maternal age. We're all very familiar with the challenge of reproduction, that as women get older, it gets harder for them to achieve a pregnancy. We know that it can increase implantation success, and that's because aneuploid embryos are much less likely to implant. One of the benefits of PGS that I think has not been talked about enough is that it can reduce miscarriage rates. And I'm going to talk about some really good data about the reduction in miscarriage rates. And we certainly know that that's really significant to patients to achieve that much longed for pregnancy only to have it slip away. And I think what's really relevant to India, but not just India, many countries still, is the ability to confidently select the best single embryo to perform single embryo transfer and of high pregnancies. And I think that this has really been one of the key outcomes for countries like the United States, where patients are now far more willing to transfer just one euploid embryo. And I'm going to talk you through some really compelling data about that, which I hope will resonate with the Indian IVF scenario as well, even though it's obviously American studies. So I'd first like to talk through some early PGS data, and I'm sure for every good PGS news story or publication, everyone's heard some bad data as well. And the reality is that there is some very negative PGS data, and it's really important that we don't, I guess, collectively talk about PGS without differentiating the type of technology that was used and the methodology as well. So I want to talk to you about FISH, or fluorescence in situ hybridization, and to do that I'm going to talk about the Mastenbroek study from 2007. Now this was a randomized controlled trial from the Netherlands, and what they did is they looked at approximately 200 patients in each group. One patient had what they called routine IVF, where the embryos were selected for transfer based on their appearance or their morphology. And the second group had a day 3 embryo biopsy, and they did PGS with FISH. Now, really disturbingly is they actually found that PGS through this methodology reduced the ongoing pregnancy rate and the live birth rates. And these were women of advanced maternal age, so they didn't have a lot of embryos and they didn't necessarily have a lot of hope or a lot of chances. Now, there were actually, I believe, 8 other randomized control trials that followed, all looking to repeat a similar study, and they all found essentially the same outcome, that PGS did not benefit these patients. But of course, as I mentioned, with any set of negative data, there's some really important considerations. And so if we look just briefly that in the 2 years following this landmark Mastenbroek paper, you can see on the left there that there's a number of responses that talked about some of the challenges and limitations with this study and the studies that followed. Some of those limitations and likely causes of the negative or ambiguous data may actually be due to the way that the embryo biopsy was performed, or a lack of embryo biopsy experienced. We know that the error rate with FISH is incredibly high. It's usually, the published data says it's around 11%, and this can be impacted and increased with poor fixation of the blastomere and the nucleus to the slide. Looking at a limited number of chromosomes, on average, FISH studies would look at 5 chromosome pairs. Of course, we know that there's significantly more that we need to be looking at. And they did miss some really common chromosomes associated with miscarriage and negative outcomes. If we look at the methodology for some of these studies, they did do embryo biopsy of embryos with a low number of blastomeres on day 3, so the minimum was 4. Most clinics now, if they are still doing blastomere biopsy, the minimum number would be 6, but preferably 8 cells within the embryo, and taking up to 2 cells, which is a huge proportion. And so combining these limitations and then talking about newer studies, we really need to question whether or not the studies were performed in the best possible scenario. And one of the points that's really important about PGS, and this is relevant at a global level to every lab around the world, is that PGS can only complement IVF, and it works best with really good IVF and embryology practices. It cannot fix poor quality IVF or embryology. You have to have very good laboratory practices and clinical practices to get the best out of PGS. So I mentioned already some of the limitations of those older studies, and the randomized control trials with fish have not shown consistent results, and many of them have been negative, which we know. We know that day 3 embryo biopsy has likely played a significant role in these negative outcomes. And there's a fantastic study from Richard Scott and Nathan Treff who showed that by performing cleavage stage biopsy, it actually reduces the implantation potential of the embryo by 39%, which is huge. It's just from that intervention on that particular day. Conversely, doing blastocyst biopsy does not impact on the embryo viability and reproductive potential. So we've come a really long way with our ability to do very good embryology and move towards blastocyst biopsy. I will say that there's some really good studies that show that day 3 biopsy can result in improvements in pregnancy when combined with PGS. And again, it comes back to that very strong embryology skill set. So I do want to talk now a little bit about the more recent studies and how the introduction of newer technologies where we can test all of the chromosomes and do blastocyst biopsy have shown more consistent results. So I really want to focus now on the positive and on the benefits of PGS. And so just to quickly explain some of the technologies that are in the data that I'm going to talk about, we're going to see data about array aCGH, which was introduced in around about 2008 and really led to what I guess I would call the reluctant PGS revolution. So there was a slow uptake of the technology when it was first released because of these fears from the early studies. But slowly we saw it become very, very well adopted, and we saw really high utilization of PGS. I'm also going to talk about next generation sequencing technology, which was first released commercially in 2014. So it's actually quite well established in the market. And some of the studies will also talk about quantitative PCR as well. It was used in a very small number of laboratories, and I believe is actually not used very frequently anymore. So I'm not going to talk about these studies on this slide because I am going to talk about them in more detail in the coming section of this presentation. But I really just wanted to give you a snapshot of how much data exists that shows benefit of PGS. And actually this is just, you know, the tip of the iceberg. What we have at Illumina is a summary booklet of publications and abstracts related to our PGS technology, and actually we can't keep it up to date because there's so much data that's coming out. And you know, but we really do like to stay on top of the data that's coming from our technology, and really like to see the positive outcomes for patients. So what I want to start with here is just maternal age. It's something that we can't change in our patient population. If the patient is 35, that's probably going to be great. But if the patient's 40, we can't undo that with any medical intervention. And so this really nice study from Gary Harton was performed to look at the impact of maternal age on implantation rates, aneuploidy rates, and pregnancy loss or miscarriage rates. And he did this in defined patient age groups. And you can see that there's only a sort of about 2,500 embryos included in this, but what you'll see is that the data is quite compelling. So if we look at our patient age groups there along the bottom, and as expected, the rates of aneuploidy increase with increasing maternal age. And for those who are maybe not familiar with the expected rates of aneuploidy, this is what we would expect to see. Personally, I think that at the older end of the graph, it's quite generous, and I perhaps wasn't quite so lucky when I was informing patients of their PGS results. It would generally be a bit higher, but we do expect it to go up with maternal age. Now, if I add in here implantation rates in green and miscarriage rates in grey, what you can see, and I really want you to focus on the green bars there, the implantation rates, is that they're all roughly between sort of 40 to 50%. And so what that means is that being able to selectively transfer a euploid embryo actually undoes the adverse effect of maternal age on implantation rates. Now, we can't make the embryos euploid, and that's often quite difficult for these older patients, is to actually get a euploid embryo. But we also have to remember that transferring an aneuploid embryo does not get them that pregnancy that they so desperately crave. And that's what we're aiming for. We're not aiming for an embryo transfer. That's great, but what we want is a healthy pregnancy and a live birth. So this really, when I talk about that PGS resolution, this was really the paper that did it. Zihong Yang from Vladogen looked at young, good prognosis patients having IVF for the first time and no history of miscarriage. They performed PGS in their study group with a day 5 biopsy, and they did a day 6 fresh transfer, which is quite common in the US. Their control group was well-matched patients where they just looked at the embryo morphology alone and did a transfer on day 5 of the best looking embryo. And so what you can see is that we have, oops, sorry, I just a little bit too fast there. What you can see is that we have a significant increase in the clinical pregnancy rate and the ongoing pregnancy rate in the patients that had PGS. And what that actually represents for those patients in the ongoing pregnancy rate is a 65% relative increase in the pregnancy rate, which is so huge and so compelling for those patients. We didn't see any significant difference in the miscarriage rate, but the numbers were so low that it was going to be very difficult to achieve any statistical significance. If we look at this fantastic study, again from Richard Scott and Nathan Treff, and they've contributed a huge amount to the knowledge biobank for PGS. They looked at a non-inferiority trial. So they really wanted to challenge the norm that existed in the US, which was if a patient didn't get pregnant, then they would put back 4 embryos. And in this example, the control group was putting back 2 untested embryos versus the study group where they would put back 1 euploid embryo. So what we're looking for, because this is a non-inferiority study, is we want to see that PGS doesn't perform worse than what is considered the standard of care in the US. So I really like this, this study because I think it's really important to show that by putting back more embryos, we don't get more ongoing pregnancies. What we get, though, is a whole lot more multiple gestation pregnancies. Now, I think it's really surprising that in the single embryo transfer group, there were no multiple pregnancies. We wouldn't expect it to be that way all of the time. But you can see that in the untested 2 embryo transfer group, we see about almost half of those are actually multiple